So coming back to your specific area of expertise, you were saying about the things that are most useful at the present time for dealing with coronavirus.
Well, we talked about the three methods of transmission.
Yes, that's what I want you to say.
So the most dangerous thing is face-to-face talking.
Which we're doing now.
Which we're doing.
Yes.
But family continues. So.
Yeah.
So whenever we speak, there are droplets that come out, and when we speak loudly or get excited, there are a lot more droplets that come out. Unintentional. Oh, sorry.
Yeah.
But
Unintentional.
But these can carry viruses, and so this is the most dangerous thing that we do is talking face to face, and we can control it with masks and with distance. Then the next thing is that those droplets can land on things, and then we touch those things and probably touch our face, which we do all the time without thinking, and that becomes a vehicle of transmission. Now, in the last few weeks, the CDC is kind of downplaying that. Well, we can control that by washing, and of course, it's still important to keep our hands clean so that we're not transmitting things from objects to our faces. But it seems to be less important than we thought at first. Then the third way.
Would you still wash your hands?
Oh yeah, I wash my hands all the time.
Yes.
And I use a lot more soap and I do it a lot longer than I used to. Then the third way, which is something that hasn't received as much attention as we're beginning to see it's more important, is that the smallest droplets can dry and float in the air for a considerable period of time. The big droplets fall out of the air. And so if we're protected with a mask or a distance, they're gone. The smaller droplets can dry and float. And it's maybe a little bit like the smoke of the incense. It doesn't last for hours, but certainly for minutes, and maybe in minutes to 2 hours, these things float in the air, and they can be breathed in. And if enough are breathed in, then there's a possibility of developing disease. There, the important thing is ventilation, that we don't spend too long in places that are quiet and poorly ventilated. And of course, when we add a lot of talking or singing to that, then there's more virus going out, staying around longer.
Or more aerosol, which may have virus. The aerosol comes. I remember you saying, well, when you sing, if you don't do it right, you produce a lot of this aerosol. And I said, no, I'm sure when you're singing, if you do it right, I mean, it's painful for me to admit. I was a choir director. I think I was a choir director when you first met me. Our bishop was a choir director. We both love being on the Klooster. We love singing. We love making music with other people. And there's a kind of intimacy to be on the Klooster singing in the choir. And so it's painful to have this. It's painful to have this attack, and some people don't understand, or maybe they don't want to understand. But there isn't a way for us to have unsung worship. Singing is not a hymn we pick out of the hymnal at or that our worship leader decides to inspire us with before we get down to the real service, or which could be omitted. Singing is, and I know this is true of Muslims and Jews. It's true of, I suppose it's true of Buddhists too, but I really thought much. But there are other people for whom, that singing. So I mean, at our church we have one chanter who is at greater distance. She's at least 12 feet away from everybody else during the service, and she's mic'd. It's less than ideal, but it allows us to accomplish the service in as traditional a manner as possible. So I also wanted to definitely get to you about the numbers, because every day I look at the Wikipedia pages, and the pages on the world epidemiology, when it puts the U.S. next to other countries, are always a little bit more than the ones that when you actually click on the United States. So explain that to us.
these are battlefield numbers. We're trying to keep some counts that can guide policy. None of the accounting systems are ideal. They're not meant to be ideal. They're meant to have a count that's reproducible so we can compare it to the number we got last year.
Is this the way it would always be done?
Yes, in epidemiology we call it a surveillance definition.
Okay.
So it's simply to get a running count that's a fairly reasonable.
So we shouldn't expect that there's somebody deliberately fiddling them because this number is always a little higher than that number. They're always within spitting distance of each other, the two numbers that I've been looking at, but yeah.
But it depends on when the report came through that day. What systems being used to compile them, because this goes up a chain. We have hospitals reporting to counties, the counties reporting to states, states reporting to the federal government. I'd be very suspicious if the numbers were exactly the same. Somebody would have cooked that.
Well, that's actually kind of one of the things we say about the four gospel accounts is that actually the fact that they're not coordinated and there's I think a convert to Christianity who used to be LAPD detective, and he said no, the four gospels is like the witnesses. If your witnesses come in and have precisely the same story down to every detail, then they've cooked it. And one of the reasons why he decided to try to follow our Lord Jesus Christ was because the testimony of the four gospels struck him as real testimony. I hadn't thought of that until just now, but I mean, so it's not only possible but likely that these numbers will be adjusted.
Oh yes, we have rough counts now, particularly death numbers. The final counts will involve death certificates and clinical records that have all the relevant data, and of course we know that people who are sick are at higher risk of COVID. So we have to consider all the diseases they had, what role that played in their death. And there's rules for this, there's specialists in this, but it takes 2 or 3 years for the final numbers to come out. In the meantime, we need something just to keep track of where we're going. Are things getting worse? Are things getting better?
But as we were saying earlier, we wouldn't say for a cause of death that if somebody were hit by a car, we wouldn't say, oh well, they were undergoing chemo anyway.
No. The cause of death is the accident.
Yeah. Even if the person had they been in full health would have survived the impact. So it would be normal that the numbers fluctuate a little bit, but you don't expect the numbers to go down significantly to discover that there were far fewer deaths than they reported.
There are probably errors in both directions. There are people who had COVID but didn't die of COVID and are being counted as COVID. But there are people who may have gotten sick very suddenly, died at home without being tested, and they won't be counted unless the coroner does a test on them, which will take several weeks.
Oh, okay.
So
if it happens at all.
There are errors in both directions. I couldn't say whether the final number will be higher or lower.
You wouldn't expect it to be to discover that really only 20,000 people died of COVID. That was just all over the
I wouldn't expect
that. or something.
Yeah.
I mean, we're facing something that is serious enough to be a problem, and yet, it isn't like Ebola or bubonic plague with people just dropping. Though, it certainly did get close to that in New York, and it was definitely getting that way in Spain and Italy at some point.
Well, and we have different numbers. We have deaths, but they're not very good for planning because they take several weeks. We can't tell what's happening right now by looking at deaths. And then we have test results, but not everybody gets tested. And then there are times at the beginning and again right now where it's hard to get a test. So there are limitations in the testing data. We can look at hospital data and ICU data. I think the hospital data is fairly reasonable. Doctors don't want to admit somebody else they're really sick, but they do want to admit that they are really sick. At the beginning, there were a lot of concerns about what's going to happen with all these COVID people in our hospital. Are things going to get much worse and we won't be ready for it? So there were some distortions at the beginning. But I think the hospitalization numbers are fairly reasonable, and they have a smaller lag from the beginning of the infection. And we can see the hospital numbers went up, came down a little bit, depending on the areas. Some in the east came down quite dramatically, and then have come back higher now, particularly throughout the south, including Southern California.
Well, something that was pointed out to me today, and I meant to mention this to you before we started, but was that the numbers, the death numbers, were rather small, even though the other numbers were spiking. But then yesterday and today, the death numbers started to spike. So he was saying, well, of course, the spike started, 2 to 3 weeks ago, and now the death rate. I thought that the lower death rates might indicate that we're better at treating it, which I think we are. But, So do you find it imaginable that hospitalization in Southern California will be taxed?
I think so, and I think there are places where it already is being taxed.
How do you feel in your hospital?
Right now, I think we're still feeling like we've got our heads above water, and we have enough personal protective equipment, ventilators, and supplies. I think nursing is being stretched.
Now.
Now.
Yeah.
I think nursing is definitely.
But you can't stockpile that.
No.
The people,
Well, yeah.
the people you need, and the people have lives. They have their need for rest.
And they can also become ill. They have elderly parents at home or other vulnerable family members. So it really is a very complex problem.
And already in California, we've had shifting between areas. That Imperial County a few weeks ago was overwhelmed, and there were a lot of people transferred to San Bernardino and Riverside counties. So we have there's some ability to move people around, but it's still a system that's dealing with an awful lot of illness.
And I know many hospitals in our area are looking at alternative places where patients can be hospitalized, so that if the hospital beds themselves are completely filled, they still will be able to care for patients in either a situation where tents have been set up, or there have been blocks of hotel rooms that have been used. So there are a lot of different ideas that are being used to look at that to try.
But we're not there yet.
We're not there yet.
Okay.
No, we're not there yet.
So,
One of the things that we talked about earlier was what we can do about aerosols versus ventilation. But I know you've been meeting outside.
yeah, our liturgy is outside. Yeah.
And it seems like that has a number of advantages. That people can separate as much as they feel the need to.
Well, it's mandatory that they separate. We have little pieces of tape all through the courtyard.
And yet the courtyard is big enough that can accommodate a lot of people.
And people could go down the sidewalks, or we're not at capacity. Many more people could come if they wanted to. Also, right now, with fluctuating California things, it's disrupted our own celebration of the liturgy very little. It's disrupted our, when the state comes out and says, no, close this, no, open, close, open, we've just been doing the same thing. We didn't, I think, initially believe that we would be outside for as long as we have been. and to be really honest, though, I mean, like, I prefer being outside and able to administer the holy gifts to as many people as possible than to being inside with 3 people as we were before and not having liturgy and so forth. And that's something I guess we'll close on saying, but I wanted to ask you one more epidemiological question. I know we've got over what we expected to do, but one thing is that a lot of people have said to me that they believe, and it seems reasonable to me, that many more people have been infected than are reported. So today we hit reportedly over 4 million cases that are tested and reported, but that many more people than that, and that this would affect what the death rate is per infection.
Yes, that's true. And there was a report this week from CDC, which was looking at routine clinical lab specimens, which is not a perfect random sample, but a pretty good sample of the population. And they found a lot more people had some evidence of immunity, which would indicate they'd been infected. So yes, that when we calculate the death rates for infection, they're much lower than we calculated per identified individual. It's still an awful lot.
Yeah.
And we start out with no immunity at all.
Yeah.
So if we were to go, if the infection were allowed to proceed naturally until there weren't enough susceptible people to carry it on, that would be 60 or 70% of our population, and hundreds of thousands of deaths. And if we can do some reasonable things to control the infection, then we don't have to have that number of deaths and the number of people who've just been terribly sick.
And it's unknown what long-term consequences might be for people who may have even had a fairly mild
we're
illness.
getting at least, I mean, we were talking about the difference between anecdotes and data at dinner this evening, but, but there's enough anecdotal data to say that there's some people that have suffered long-term loss of breath.
And on the other hand, there are things we can do without completely shutting down. That by being responsible, a reasonable kind of distancing, masks, things like this, we can slow down the transmission while treatment isn't improving and decrease the final death toll. One of the things that has really bothered me, I'm going off topic a little more, is the yes-no thinking. Either we do whatever we want or we shut down. Either we have school for everybody or we have no schools at all.
Oh, yes.
But if we're smarter about these things, we can limit the infections without closing every business. Maybe we can begin to think about the younger school-age children who are
at comparatively less risk.
Than teenagers and college students. So let's do the things that we know work, and we're learning a lot more as we go, without insisting that everything stop.
Or that everything go back to exactly the way it used to be.
Yeah. Well, I mean, sooner or later, equilibrium will come back to most of those things, I think.
But the world will be different.
Well, yeah.
How many businesses are going to spend thousands and thousands of dollars on new filtration systems?
Well, that's There are a lot of
lots of things are going to be different.
Yeah.